Sesión Ordinaria Mensual de la Sociedad Médica de Médica Sur. Es la última del año, así que muchísimas gracias por acompañarnos el día de hoy. Mi nombre es José Manuel, yo soy el tesorero de la sociedad. Nos acompaña la mesa directiva, presidida por el doctor Arturo Mendoza. Y el día de hoy tengo muchísimo gusto de poder presentar ponentes tanto nacionales como internacionales. Vamos a hablar acerca de la ruta del hepatocarcinoma. Y primero va a hablar el doctor Emilio Conde Flores. A Emilio lo conozco desde que era residente de medicina interna aquí en el hospital. Posteriormente hizo oncología médica y tiene una alta especialidad, un fellowship en tumores del tracto gastrointestinal. Y posteriormente, después nos va a hablar Emilio acerca del carcinoma hepatocelular como su panorama actual en nuestro país, en México. Y posteriormente va a hablar el doctor Amit Singal. Él nos va a hablar acerca del régimen STRIDE. El doctor Singal es profesor en la Universidad de Texas, en el Southwestern Medical Center. Y revisando su currículum, pues era bastante extenso y me dijo que entre más extensa la presentación del ponente, peor era la plática, así que lo mantuviera corto. Este régimen STRIDE, abriendo nuevos caminos en el tratamiento del carcinoma hepatocelular no resecable. Les pedimos que las preguntas las dejen al final. Vamos a tener un foro abierto para preguntas. Muchísimas gracias por su asistencia y adelante, doctor Conde. Muchas gracias por su asistencia.
¿Cómo están? Buenas tardes. Gracias por la invitación, primero a Médica Sur y posteriormente a AstraZeneca. Gracias a todos los que están aquí en el auditorio. Vamos a hablar un poco acerca de epidemiología que tenemos en México y vamos a ver que es una epidemiología relativamente pobre en investigación porque literalmente son estudios retrospectivos aislados. El máximo número de estudios que tenemos es con 200 pacientes y es un gran reto que hicieron el grupo de 3 hospitales, entre ellos incluidos Médica Sur, con el doctor Norberto Chávez, en el cual hablan acerca del panorama que tenemos actualmente en México. Estos son mis disclosures. Vamos a empezar y siempre me gusta empezar las pláticas de carcinoma hepatocelular con que tenemos una dualidad en esta enfermedad. Siempre hablamos de 2 enfermedades, una enfermedad hepática crónica y el carcinoma hepatocelular, y desde ahí partimos porque es importante determinar que muchos de nuestros tratamientos del carcinoma hepatocelular están ligados con una buena función hepática. Si no tenemos una buena función hepática, automáticamente estamos mandando a nuestro paciente a cuidados paliativos. Tenemos que siempre una enfermedad produce un daño hepático crónico y posteriormente una cirrosis que va a iniciar de forma compensada. Sin embargo, esto se vuelve más complejo porque tenemos pacientes sin hipertensión portal, con hipertensión portal clínicamente significativa y con varices esofágicas, y esto del 5 al 7% de forma anual va a producir una cirrosis descompensada que nos va a limitar o va a ser una escalera en nuestro tratamiento, donde va a haber complicaciones como ascitis, encefalopatía hepática, peritonitis bacteriana espontánea y sangrado varicial. Sabemos que el daño hepático crónico es la primera causa de carcinoma hepatocelular. El riesgo de que este se vaya a desarrollar es del 1 al 5%, y algo importante, es la primera causa de muerte en pacientes con alguna enfermedad hepática crónica. Menos del 15% de sobrevida a 5 años con diagnósticos en etapas avanzadas, y eso gracias a los tratamientos que tenemos actualmente, principalmente a la doble inmunoterapia, donde ya podemos hablar de un 15%. Anteriormente no hablábamos más de 2 años con los TKIs, entonces hemos ido evolucionando. 40-70% de sobrevida tenemos si los encontramos en etapas tempranas. Entonces tenemos que ir haciendo cambios en nuestro paradigma. ¿Por qué? Porque también nuestras terapias de tratamiento actual, cuando no hay enfermedad extrahepática y se limita solo al hígado, también podemos llegar a convertirlos en un tratamiento curativo. Recordar que el 95% de los pacientes vienen de una enfermedad hepática crónica, 70-90% de los pacientes tienen una fibrosis avanzada, Hay que entender que una descompensación de la cirrosis conlleva un peor pronóstico, una limitación en la tolerancia y respuesta del tumor, y que es una decisión incorrecta por parte de los médicos que estamos tratando carcinoma hepatocelular. Es decisivo al momento de hacer una descompensación, y este es si llevamos a nuestro paciente a una descompensación, es un factor pronóstico de forma independiente a la mortalidad. Y ahora sí vamos a ver la importancia de por qué el carcinoma hepatocelular a nivel mundial ocupa el 8º lugar en incidencia, con aproximadamente 800,000 diagnósticos. Mortalidad, ocupamos el 4º lugar, con aproximadamente 758,000 muertes. Pero ¿qué pasa aquí en México? Ocupa el 12º lugar, con aproximadamente 8,000 pacientes diagnosticados en los últimos años, y a nivel de mortalidad ocupamos el 8º lugar con 7,673 pacientes. Esto es importante también en la estadística de Globocan en NSCN. Algo importante y que también tenemos que ir cambiando nuestro paradigma es que, aunque todavía sigue siendo la hepatitis B uno de los factores etiológicos importantes, y esto porque la mayor incidencia se encuentra en Asia-Pacífico, tenemos que ver que hay una transición epidemiológica a nivel occidente, donde a nivel Europa es la principal causa, puede ser virus de hepatitis C, pero ya está incrementando la causa alcohólica, y a nivel de Norteamérica, Latinoamérica y Sudamérica, aunque todavía hay algunos indicios de virus de hepatitis C, la transición está viéndose reflejada a un MAFLD o hepatitis por alcohol. Entonces también tenemos que ir cambiando nuestros paradigmas al momento de hacer los diagnósticos. Es importante también conocerlo como a nivel mundial, aunque les digo que todavía sigue habiendo un importante incremento del virus de hepatitis B, y esto es porque hay mayor incidencia en Asia. También es importante saber que en América y sureste asiático la mortalidad sigue incrementando, la incidencia y mortalidad han ido en aumento, pero ahora principalmente por enfermedades metabólicas asociadas, y esto produce daño crónico y conlleva carcinoma hepatocelular, y la tasa de mortalidad por virus ha disminuido. Sin embargo, recordemos que aunque hay tratamientos de análogos nucleócidos, también hay vacunas para virus de hepatitis C. Esto también no está bien implementado en nuestro sistema de salud. Recordemos que solamente hasta un 20, un 30% de los pacientes tienen accesos a un buen tratamiento para virus de hepatitis B, a un buen tratamiento para virus de hepatitis C. Entonces, esto todavía no ha sido reversible en nuestro país. Este estudio es el que les decía que en donde participó Médica Sur, pero también participaron hospitales del norte, hospitales del sureste, también hospitales públicos como el 20 de noviembre, el Hospital Central Militar, en donde fueron 3 hospitales, 2,000 pacientes se fueron documentados, en donde la prevalencia de la insuficiencia hepática crónica es predominante en mujeres versus en hombres. La edad promedio sí está respecto a la edad global, que es de 58 años de edad. La mayoría de estos pacientes principalmente fueron de la región centro, y se diagnosticó un 8% de carcinoma hepatocelular. Algo importante es que de este 8%, la mayoría fue mujeres en un 55%, la edad promedio, vean, arriba de 60 años de edad. Entonces no solamente tenemos que integrar aquí en México al médico internista, al hepatólogo, al gastroenterólogo, sino también al geriatra, y que nos haga una buena valoración de estos pacientes. Hasta un 73% eran mayores a 60 años, pero vean, entre 71 y 80 era el 36%, un tercio de la población de carcinoma hepatocelular ya tiene mínimo un síndrome geriátrico, mínimo comorbilidades con la polifarmacia. Entonces ya es importante integrar en nuestros equipos multidisciplinarios al geriatra. Causas etiológicas, vean, hay una transición, anteriormente era el virus de hepatitis C, pero vean, la causa metabólica ya es una de las principales causas, hasta en un 40.2%, y seguido por etiología alcohólica. Aquí les dejo esta gráfica en donde podemos observar cómo, de acuerdo a que si eres mujer o de acuerdo a si eres hombre, vean, la enfermedad metabólica está asociada hasta en un 44%, 42% por virus de hepatitis C, solamente un 2.8% por enfermedad asociada a alcohol. Pero ¿qué sucede en el hombre? Hasta en un 39% la cirrosis es por enfermedad asociada a alcohol, seguido por enfermedades metabólicas y hasta en un tercer lugar por virus de hepatitis C. Entonces ya está cambiando esta transición epidemiológica. Aquí podemos observar que entre mayor edad, mayor asociación a un síndrome metabólico. Vean, los mayores a 71 años, el 45% está asociado a una enfermedad metabólica, y de acuerdo si es región centro o región sur, vean, la región sur es hasta en un 68%, en la región centro solamente un 40%, pero la mayoría está combinada, alcohol más enfermedad metabólica, y esto también es importante al momento de nosotros ir haciendo los tamizajes, encontrar hallazgos y los pacientes oportunos para encontrar enfermedades crónicas y posteriormente el tamizaje que nos haga incidir en la detección del carcinoma hepatocelular en etapas tempranas. Estos son artículos retrospectivos más pequeños, en donde fueron 43%, esto es del Seguro Social. La causa principal es enfermedad metabólica asociada a alguna alteración metabólica, seguido de viral y en tercer lugar por alcohol. Algo importante es, la mayoría de nuestros pacientes los encontramos en enfermedades avanzadas. El problema es que todavía no se han subclasificado el Barcelona B, y esto es porque a partir del 2022 fue los subtipos del Barcelona B en B1, B2, B3. Entonces aquí es importante también identificar que todavía nos falta identificar cuáles son los pacientes que tenemos de acuerdo al Barcelona. Y esto es importante porque la mayoría de los pacientes se encuentra en enfermedad irresecable, probablemente sin riesgo a tratamiento locorregional, y probablemente van a ir a tratamiento sistémico. Lo importante es que se encontraban con buena función hepática, lo que nos haría acreedores a un buen tratamiento sistémico. Este es otro estudio retrospectivo, esto es en el ISSSTE, en el cual la mayoría es por alcohol, esto es algo importante, seguido de cuestiones virales, todavía nos siguen afectando, y posteriormente por enfermedades metabólicas. Algo que me llamó la atención es que el 40% todavía necesitamos diagnóstico por biopsia. Esto yo creo que es un problema a nivel de nuestros seguros, tanto Seguro Social, ISSSTE, y esto es porque para justificarte un tratamiento hay algunos evaluadores que todavía te piden biopsia, y recordemos que el carcinoma hepatocelular en un hígado cirrótico, el diagnóstico es por imagen, no necesitamos biopsia, y esto conlleva a veces a retrasos y mayor gastos en nuestros pacientes. La mayoría se encuentran igual en Barcelona B, Barcelona C, pero algo importante, creo que encontramos pacientes en Barcelona D, y esto se debe por retrasos diagnósticos, por mala referencia por parte de nuestros compañeros de medicina familiar, o muchas veces una vez diagnosticado se están botando a los pacientes entre consultantes, y eso a veces hay un retraso de aproximadamente 8 meses hasta un año, y esto hace que progresen los pacientes y tengan falla hepática. La mayoría de la función, aunque los tenemos con buen funcionamiento hasta el 53%, vean, Chalpuk B en un 34% y C 13%, este grupo en algunas ocasiones ya no les quieren dar tratamiento, y tenemos que tener claro que actualmente los pacientes con carcinoma hepatocelular con una función hepática crónica son pacientes dinámicos. En el momento de la consulta podemos ver que no reciben tratamiento por una función deteriorada, pero si corregimos lo que descompensó al paciente, podemos llevarlos a tratamientos sistémicos. Y algo importante, solamente vean, el 16% de los pacientes tenía acceso a tratamiento, y esto es muy bajo porcentaje. En el Instituto Nacional de Cancerología, un instituto de referencia, 225 pacientes. Vean, la transición epidemiológica ya está viéndose más por enfermedades metabólicas, virales en un 21%, alcohol en un 14%. Algo importante, la mayoría se encontraba en enfermedad irresecable o Barcelona C, y la función hepática la encontramos en un 73% con buena función hepática. Sin embargo, todavía estamos teniendo un 27% de pacientes que probablemente no van a recibir tratamiento sistémico, y en una función calculada por ALBI, hasta en un 36% de estos pacientes no estaban recibiendo tratamiento sistémico, y la justificación era porque no había un hepatólogo, no había un médico internista que nos apoyara al momento de compensar a estos pacientes. Y en Médica Sur también se hizo un estudio retrospectivo de 111 pacientes, el 49% eran cirróticos. Vean, igual aquí, algo diferente, todavía hay etiología viral, aunque el porcentaje es bajo de enfermedades metabólicas y alcohólicas. Esto se debe que por aseguradoras anteriormente no estaba detectada la enfermedad hepática crónica asociada a alguna alteración por metabolismo como una enfermedad, entonces no la cubría el seguro, y por ende tendríamos que ponerle como criptogénica porque el seguro no te iba a cubrir este tipo de enfermedades. Entonces algo también tenemos que hacer el cambio para las aseguradoras de decir que la enfermedad hepática crónica asociada a alguna alteración metabólica es enfermedad y tenemos que tratarla. La etapa clínica, la mayoría de nuestros pacientes eran enfermedad avanzada, Barcelona B, Barcelona C, y la función hepática, aunque estaba bien conservada en un 56%, vean, estos pacientes estaban danzando en tratamientos y probablemente no fueron ofertados a tratamientos sistémicos avanzados de doble inmunoterapia o inmunoterapia antiangiogénico. Con el ALBI 2 igual, la mayoría de nuestros pacientes tenían alguna alteración o alguna función hepática deteriorada. Y algo importante, y con el que cierro la plática y doy paso a la discusión del tratamiento, es que recuerden que esta es la actualización de Barcelona 2025, y algo importante es, siguen con la subdivisión del Barcelona B, en donde tenemos en B1 es el Barcelona B que conocíamos con criterios extendidos para trasplante, el B2 es el Barcelona B nato al que solamente le ofrecemos tratamientos locorregionales, pero encontramos ya el difuso, el infiltrativo, el bilobar, en donde nuestro objetivo primordial tiene que ser preservación hepática y por ende tenemos que tratarlo como un Barcelona C con tratamientos sistémicos. Esa es una de las actualizaciones que hay. Ahora, algo importante es este abordaje QS, en donde hay una complejidad, es incierto, subjetivo y debe de integrarse cuestiones emocionales al momento de definir nuestro tratamiento en un paciente hepático crónico. Y algo importante que integran las guías es cuál es mi objetivo de tratamiento y que la función hepática en un paciente es dinámica. Si ahorita no puedo darle tratamiento, mándalo con el hepatólogo o el internista, compénsalo y posteriormente revalora al paciente porque probablemente encontraron la etiología de la descompensación y probablemente en la siguiente etapa tú ya puedas dar tratamiento sistémico y no mandarlo de inicio a un tratamiento paliativo. Muchas gracias.
Muchas gracias, doctor Conde, por su excelente presentación. A continuación, tengo el honor de presentar al doctor Amit Singal. Él es profesor en la Universidad de Texas en Southwestern Medical Center. Tiene estudios en medicina interna, gastroenterología y hepatología, además de ser un experto internacional en carcinoma hepatocelular. Muchas gracias, doctor Singal, por su asistencia.
Thanks so much. So it's an honor to be here. I want to start by thanking you all for taking time out of your day to attend the lecture. Thank AZ for putting this together. And then thank Dr. Conde for his excellent lecture talking about the epidemiology of HCC. Over the next 20-30 minutes, I want to talk about the advancing landscape that we've seen for systemic therapies for HCC, and how we can think about approaching these patients with systemic therapies, including the STRIDE regimen. Here you can see my disclosures. So we've heard once again from Dr. Conde about the epidemiology of HCC from a global perspective. I just want to highlight a couple things as he pointed out. Here in Mexico, we do see an intermediate incidence and mortality rate compared to other parts of the world, including East Asia and in Africa. And as he nicely pointed out, I think the high mortality that we see in many of these regions continues to be because we see frequent late-stage diagnosis when we no longer have curative therapies available. And so one of the key things that we really need to do if we want to reduce mortality is to improve early detection through better implementation of surveillance programs. Now, the good thing is that even for these patients who have unresectable disease or non-early stage disease, we've seen tremendous improvements in our treatment approaches, improvements in our local therapies, as well as improvements in our systemic therapies. Here we can see the exciting landscape for our systemic therapies for unresectable HCC. For those of us who have been treating HCC for many years, remember the days of having a single systemic therapy agent available, sorafenib, available first in 2007, and created some excitement because it was a systemic therapy that we had, albeit with a 3-month survival benefit and a median survival below a year. But the biggest reason for excitement was because we thought other agents would be shortly following. And instead, we had a period of 10 years where we had no other therapies approved in the first-line setting. It wasn't until 2018 that we had our next first-line systemic therapy available, lenvatinib, showing non-inferior survival, although improvements in objective responses and progression-free survival. We then had the failure of single-agent IO therapy with Checkmate 459, specifically nivolumab, failing to improve survival compared to sorafenib. And it wasn't until 2020 that we started to see agents that significantly improved survival compared to sorafenib and TKI-based therapy. 2020, we had the introduction of atezolizumab and bevacizumab, so a PD-L1 plus an anti-VEGF therapy. 2022, we had the STRIDE regimen, a single dose of tremelimumab followed by repeated intervals of durvalumab thereafter. And most recently, we've seen the introduction of ipi-nivo. Once again, the same combination of an anti-CTLA-4 combined with an anti-PD-1, PD-L1. All of these showing superior results compared to TKI-based therapy, and we'll go through each of these trials in detail. So starting with IMbrave 150, we see this is the evaluation of atezolizumab plus bevacizumab compared to sorafenib, and we see a significant improvement in overall survival. In the updated analysis published in 2022, we see a median survival of 19 months, we see a significant hazard ratio, and we see improvements in landmarks at 6 months, 12 months, and 18 months. However, this is the most mature data that we have from the clinical trial, and you can see that there are few patients who have been followed out to 24, 30, 36 months. So even though we see improvements in these early timeframes, we do not have robust data to know what proportion of patients are alive during longer follow-up. Now, I'm not saying that this doesn't happen. Anyone who's used this agent knows that you can have people who survive long periods of time. It's just that we don't have robust estimates to know what proportion that entails. Now, for the IMbrave 150 trial, we also saw improvements in secondary outcomes, including objective responses being observed in 30% of patients, complete response being observed in 8%, and we also saw improvements in progression-free survival, as you can see on the left-hand side. Now, the fortunate news was that atezo-bev was well tolerated in the IMbrave 150 trial. There was some concern coming in because anti-VEGF therapy can increase your risk of GI bleeding. And as we heard, patients with cirrhosis have portal hypertension and are at risk for GI bleeding inherently given portal hypertensive gastropathy, varices, etc. Now, what we see here is that the proportion of patients who had grade 3-4 treatment-related AEs was acceptable at 44%. And we also saw that GI bleeding was only observed in 7 to 8% of patients, actually fairly low given anti-VEGF therapy. However, this was really driven by careful patient selection. All patients for the IMbrave 150 trial were required to undergo an upper endoscopy within 6 months prior to treatment inclusion, and those patients with high-risk varices, high-risk stigmata, were not included in the clinical trial, and that's why the proportion of GI bleeding was actually tolerable and low. And so it's important, if we want to see good tolerability for atezo-bev in clinical practice, that we continue to observe that practice of doing an upper endoscopy prior to atezo-bev initiation. Now, as I've mentioned, we've now seen the introduction of the STRIDE regimen as well as Ipi-Nivo, and this leverages the combination of an anti-PD-1 or PD-L1 combined with CTLA-4. So for the STRIDE regimen, it's a CTLA-4 combined with this anti-PD-L1. We know that this combination acts in 2 different sort of points in the immune cascade. CTLA-4 acting earlier in the immune cascade, acting in the lymph nodes, where you increase T cell diversity, including increased memory T cells, and anti-PD-1, anti-PD-L1 acting later in the immune cascade, thereby keeping those T cells active, thereby allowing improved responses, improved survival. And we know that this is a proven combination. We've seen data from melanoma where the combination of CTLA-4 combined with an anti-PD-1, PD-L1 has actually induced high responses as well as notable long-term duration of response and survival. You can see here survival curves from the melanoma data where you see initial drop-off in the survival, but overall, long-term, you see a flattening of that curve, an elevation of that tail, where many of these patients can have long-term responses, long-term survival, almost achieving cure in a manner. Now, the evaluation of the STRIDE regimen, this combination of durvalumab and tremelimumab, started in study 22. This was a phase 1/2 trial where we saw the evaluation of 4 arms: durvalumab monotherapy, tremelimumab monotherapy, and 2 different doses of a combination. Specifically, we saw the STRIDE regimen, a single high priming dose of tremelimumab at 300 milligrams, followed by durvalumab. We also had a different combination arm where tremelimumab was given at a lower dose, 75 milligrams, and given up to 4 times, and then sort of combined with the durvalumab. Study 22 showed the highest survival signal from the STRIDE regimen. Once again, this priming dose of tremelimumab given 1 time up front. And from a preclinical perspective, we see an expansion of T cell clones and increased T cell proliferation, going along and providing mechanistic rationale that this single priming dose was sufficient to achieve the goal that it was meant to do. Now, in the Himalaya trial, what we see is that the trial was initially designed with 4 arms. Durvalumab monotherapy arm, those 2 combinations of durva plus tremi, and then the comparator arm being sorafenib. After study 22 results came out, arm 2, where you had lower dose tremi combined with durvalumab, was closed, and arm 3, where you had the single priming dose of tremelimumab, was the one that was continued moving forward. The primary endpoint was a comparison of survival for the STRIDE regimen versus sorafenib, with a secondary evaluation for durvalumab versus sorafenib, looking specifically at non-inferiority. There were several secondary endpoints you can see listed there, and one of the key ones that we'll discuss is an evaluation of survival at a 3-year landmark. Now, I'm not going to go through the durvalumab monotherapy data in detail, but in brief, what we saw coming out of the Himalaya trial was non-inferiority for durvalumab compared to sorafenib, but it did not achieve superiority when durvalumab was used as monotherapy. Conversely, for the primary endpoint, we see a superior survival estimate for a STRIDE regimen compared to sorafenib. So the trial hit its primary endpoint with a significant improvement in OS. We can see the median survival for STRIDE regimen being 16.4, median survival for sorafenib 13.8, and you can see a significant hazard ratio listed there, point estimate 0.78. We can see improvements in landmarks at 18, 24, and 36 months, but notably when you take a survival and hazard ratio. However, it's important to note for the hazard ratio to really reflect the overall benefit that those curves need to meet the proportional hazards assumption, i.e. the relative benefit of a therapy versus the comparator should be stable over time. However, with immunotherapy-based regimens, we often see non-proportional hazards. In this case, increasing benefit over time. Conversely, for IMbrave 050, where we looked at the evaluation of atezo-bev after surgical resection or ablation in the adjuvant setting, we saw decreasing benefits over time. The curves initially separated and then converged during follow-up. And so, once again, if the curves don't meet the proportional hazards assumption, then actually a hazard ratio is not a good way for us to summarize the benefit of that therapy. Likewise, median survival is the estimate at a single point in time where 50% of the patients are alive and 50% of patients have died. But this doesn't, once again, summarize the overall benefit of a therapy. We've tried to highlight this on the right-hand side of your slide, where you can see, compared to the same comparator in green, we see two different blue therapies that have the exact same median survival. Although I think all of us would agree that the benefit of the blue therapy on the far right is much better than the blue therapy on the left, in part because of the greater long-term survival. And so given these concepts, it's important that we evaluate therapies, particularly immunotherapy, using different estimates, not just relying on medians and hazard ratios, but also thinking through other estimates like landmark analyses. Now, when we take a look at the STRIDE regimen, taking a look at the Himalaya data, we can see that the 3-year overall survival estimate was a pre-specified endpoint with the idea that CTLA-4 therapy works by increasing your memory T cells and improving long-term survival, not simply just moving the median over. And here we can see a significant improvement in 3-year overall survival, 31% versus 20%. Now, the Himalaya trial is one of the most mature clinical trials that we have for first-line HCC treatment. We have subsequently, after the release of the Himalaya trial, seen 4-year data, 5-year data, and actually this year at ESMO, we saw 6-year overall survival data. Here I can show you the 5-year OS, where we saw 25% of patients alive at 4 years, 20% of patients alive at 5 years, and 17% of patients alive at 6 years. Now, the easy way to remember this, and the way that I frame it to my patients, is 1 in 3 are alive at 3 years, 1 in 4 alive at 4 years, 1 in 5 alive at 5 years, 1 in 6 alive at 6 years. So that's an easy way for us to remember these estimates when we're framing these data with our patients. Likewise, sort of similar to that melanoma curve, what you can see is a flattening of this curve as we get further out. The decrement in survival between 4-year and 5 year is small, between 5-year and 6-year is even smaller. The other thing you can numerically see on this slide is the overall survival rate ratio. So for those that don't believe, sort of just like looking at them, that the curves are increasingly separating, you can see this numerically, where the overall survival rate ratio increases from 1.2 at 18 months to greater than 2 at 5 years. Once again, showing you that the curves truly are increasingly separating over time. Now, when you take a look at this, I think one of the things that we all want to know is who are these patients that are surviving a long time after the STRIDE regimen? The bad news is that we don't have a treatment response biomarker, so I can't actually tell you perfectly who are these patients surviving long term. The good news is that everyone is involved in these long-term survivors. So when you take a look at different clinical characteristics All of them are represented in patients who survive 5+ years. Likewise, when you evaluate this by depth of response, we can see that depth of response does matter. You can see that those patients who have deep, durable responses, particularly greater than 50%, have the best long-term survival. Those patients who have depth of response between 30 to 50% also have very good long-term survival. For those patients who do not have these responses, either stable disease or even progressive disease, their long-term survival is lower, but they are still represented in those patients who are alive 5 years later. Now, the beauty of the STRIDE regimen is by giving a single dose of the CTLA-4, we can achieve these good clinical outcomes, but not do this at the expense of safety. So the beautiful thing about the STRIDE regimen is that this is highly tolerable. You can see here data in terms of the AEs. We see grade 3-4 AEs only in 12% of patients, only 20% of patients requiring steroids, and notably, only 5 to 6% of patients discontinuing because of these immune-related AEs. Now, we heard from Dr. Conde that this is a disease within a disease, right? It's not only important for us to consider the tumor, but we also have to consider the underlying cirrhosis and the underlying liver dysfunction. The good news is the STRIDE regimen has consistent efficacy between different liver dysfunction groups. So whether you're LB grade 1 or you're LB grade 2-3, the relative benefit of STRIDE compared to sorafenib was consistent in these two groups. And liver function, whether you assess this by LB grade or Child-Pugh, was constant over time. So we did not see a decrement in liver function over time. And this is important, particularly based off the data that Dr. Conde already shared, that many of the patients here in Mexico have underlying liver dysfunction at the time of presentation. Now, because of these data, these have been incorporated into multiple different treatment guidelines, including professional society guidelines, the NCCN being one of these. This has also been rated as having high magnitude of clinical benefit scale according to ESMO guidelines. And so this is really one of the preferred first-line therapies that we have for patients with unresectable HCC. Now, as I mentioned, the last therapy that we've seen approved is the combination of ipilimumab plus nivolumab, another therapy leveraging the same idea of CTLA-4 plus here PD-1. This was compared to TKI-based therapy, choice of lenvatinib or sorafenib, with 75% of patients receiving lenvatinib in the TKI arm. Notably, the ipi-nivo in this was high-dose ipi. It was given 3 milligrams, not 1 milligram, and it was given up to 4 times for the CTLA-4. What we see here from the Checkmate 9DW study is first, this showed a significant improvement in survival compared to the TKI arm, hazard ratio of 0.79. You can see here the curves showing separation at long-term follow-up. However, this is not a straightforward curve. In fact, you see worse survival in the early period in the ipi-nivo arm compared to the TKI arm, and it's only after you extend beyond 18 months that you see a survival benefit in those patients on ipi-nivo. Now, we need to have better dissection of all of these clinical trial data to really understand why this occurred, but one of the contributors is the safety margin. The high rates of treatment-related AEs seen in the ipi-nivo arm, including, as I'll show you, deaths that are treatment-related in the ipi-nivo arm. Here we can see the safety profile. You see here serious treatment-related AEs, grade 3-4, observed in 25% of patients. You can see discontinuation in 18% of patients. And I understand we shouldn't be doing cross-trial comparisons, but remember, the treatment discontinuation in the Himalaya trial was much lower than what we see in this trial. We also, notably, and I think this is the thing that actually concerns me, is that we see 12 treatment-related deaths, 4% of patients. Now, we all, when we treat cancer, have patients who unfortunately die. Though I think it's different when somebody dies from the cancer or the disease versus dies from the treatment that we're giving them. And I think this is the thing that for me, at least gives me pause in terms of ipi/nivo in contrast to some of the other agents that we have available, atezo/bev and STRIDE in the first-line regimen. Now, as I said, we don't have treatment response biomarkers, we don't have treatment selection biomarkers, so unfortunately, we're forced to make treatment decisions based off of gross clinical features. Now, there are multiple different approaches that one can use when approaching systemic therapy for HCC, but here is an algorithm that I think is somewhat useful. When we see patients who warrant systemic therapy, and these can be patients either with advanced stage disease or large intrahepatic, i.e. BCLC-B disease, the first question we ask ourselves, is this patient eligible for immunotherapy? And in our clinical practice, over 95% of patients are eligible for immunotherapy if they warrant systemic therapy. Really, the ones who don't are those patients with a history of transplant or a history of severe autoimmune disease. Mild autoimmune disease, I think you can still often use immunotherapy safely. In those patients who can't receive immunotherapy, that's where you can use lenvatinib or sorafenib. But in those patients who warrant immunotherapy, the next question you ask yourselves, is this patient eligible for VEGF therapy? Clearly, the biggest contraindication for VEGF therapy would be a high risk of GI bleeding, but there are other considerations as well. Significant proteinuria, difficult to control hypertension, significant cerebrovascular or cardiovascular disease, and those patients should not receive VEGF therapy and should instead receive dual IO therapy. If one does not have a contraindication to anti-VEGF therapy, then one can consider any of these regimens, either atezo/bev, STRIDE, or ipi/nivo. And this is where shared decision-making with your patient is important. So for this part, the take-home points are really there have been marked advances in the systemic therapy landscape for HCC. We now have 3 regimens, atezo/bev, STRIDE, and ipi/nivo, that are efficacious combinations that can improve survival compared to TKI-based therapy. The efficacy of these combinations is proven not only by median survival and hazard ratios, but landmark analyses, and this is quite important when we evaluate immunotherapy. These therapies are well tolerated, although the AE profile does differ. Of course, higher VEGF therapies with atezo/bev, or VEGF side effects with atezo/bev, and we have higher immune-related AEs when you use the dual IOs. This is particularly true for ipi/nivo because you're using a higher dose of the CTLA-4 and you're giving it in repeated intervals. I didn't go through the detail, but these combinations are now being evaluated in earlier lines of disease. We've unfortunately seen negative data in the adjuvant setting, though there's a lot of hope and promise in the neoadjuvant setting. And we've seen some interesting data in the combination setting for intermediate stage patients where this is being combined with TACE and or TARE. And so we've seen improvements in progression-free survival, although we haven't yet seen any improvements in overall survival from those clinical trials. For the last 5 to 10 minutes, I just want to quickly go through a patient case that can highlight how we can make treatment decisions. This patient case started with a relatively straightforward case, a middle-aged female who has MASH cirrhosis, compensated in nature, but had a history of variceal bleed, who presents with a high AFP and undergoes an MRI. The patient has a unifocal HCC, 5 centimeters in maximum diameter, and has vascular invasion, so has BCLC stage C. Once again, Child-Pugh A, but with portal hypertension, variceal bleed, BCLC stage C disease. And so this is somebody who would have a contraindication to anti-VEGF therapy with a history of variceal bleed, would be excluded from the EMBRAVE 150 trial, and would be a good candidate for dual IO, and in our clinical practice would typically be treated with STRIDE. In contrast, you take that same patient if you did not have that history of variceal bleed, but instead had small varices. This patient would be eligible for immunotherapy, has no contraindications to anti-VEGF therapy, and so here you would have a choice of any of the first-line therapies, whether atezo/bev, STRIDE, or now ipi/nivo. And so this patient can receive any of those therapies, and this is a good sort of patient to have that shared decision-making about what is the appropriate therapy for them. Another alternative is instead of having a variceal bleed, if this patient had large varices, and instead of having VP2, so limited vascular invasion, now having larger vascular invasion going into the main portal vein. Now, arguably, this is a complex case because main portal vein invasion was included in the IMbrave 150 trial, but was not included in either of the dual IO therapy trials. So it was not included in Himalaya nor Checkmate 9DW. This was not because we thought the therapies would not be efficacious in patients with main portal vein invasion, but simply because it's a negative prognostic factor and these patients typically don't do well with any of the therapies that we currently have. Now, one of the things that I sort of approach these patients with is the knowledge that when you look at the subgroup of patients from IMbrave 150, even though the atezo-bev had consistent efficacy in both of those subgroups, we do see higher rates of GI bleeding in those patients with main portal vein invasion. We know that main portal vein invasion increases portal hypertension independently and is another risk factor for GI bleeding. So for this patient who has large varices and main portal vein invasion, I would be highly concerned for the risk of bleeding with the use of bevacizumab, and even though it's not an absolute contraindication, this is somebody who I would have reluctance to use anti-VEGF therapy and instead would lean towards dual IO therapy, including STRIDE. Conversely, if this patient had large varices without main portal vein invasion, I would feel comfortable using either therapy. Or if this patient had main portal vein invasion and had small or no varices, I would also feel comfortable with any of these therapies. And I would feel comfortable with either atezo-bev or STRIDE or ipi/nivo. This, once again, would be a discussion with your patient. The final iteration of this case is now taking a patient, the same patient has small varices, but instead of having preserved liver function that's perfect with LB grade 1, we now see that this patient has mildly elevated bilirubin, low albumin, so still Child-Pugh A, but LB grade 2. And here, once again, not an absolute sort of decision maker, but you can take a look at some of the subgroup analyses from both IMbrave 150 as well as the Himalaya trial. When you take a look at the subgroup analyses from IMbrave 150, we see the benefit of atezo-bev was greater in those patients with LB grade 1 compared to those patients with LB grade 2-3. On the left-hand side, you can see the curves for LB grade 1 separating nicely and staying separated over time, whereas LB grade 2-3, the curves are highly overlapping, and there was no definite benefit of atezo-bev compared to TKI-based therapy in LB grade 2-3. Conversely, as I've already shown you, when you take a look at the subgroup analysis of the Himalaya trial, the benefit of STRIDE compared to sorafenib was consistent if you had LB grade 1 or you had LB grade 2-3. Now, notably, survival was depressed because it is a sort of negative prognostic factor, but the relative benefit of STRIDE compared to sorafenib was preserved in this patient population with LB grade 2-3. Now, these are post-hoc subgroup analyses. These were not stratified, so there are differences between these different groups, so this is not definitive in any nature, but these are at least hypothesis generating, and in the absence of treatment selection biomarkers, these are the clinical data that I at least use in my clinical practice to help choose one regimen over the other. I'm going to skip my last iteration and move on to the Q&A since I think I've run out of time. But I'd like to once again thank you for taking the time to attend the presentation, and happy to take any questions at this time. Thank you so much.
Muchísimas gracias por la excelente presentación. Nos quedan unos pocos minutos para alguna pregunta. Pueden hacerla en español, no hay ningún problema, ya que tenemos, gracias al patrocinio, traducción en tiempo real. Invito al doctor Conde para que nos acompañe.
Bueno, antes que nada, felicidades por la presentación de Emilio y el doctor invitado. Excelentes presentaciones. Quiero mencionar que invité al doctor Naúm Méndez a venir a esta sesión, pero no pudo porque está camino a Washington, pero me comentó que acaba de publicarse o está por publicarse un estudio epidemiológico del cáncer de hígado en México y menciona justo lo que Emilio comentó de que la prevalencia, la causa de cirrosis, de etiología metabólica como causa más frecuente en México del cáncer de hígado. Parte de ese estudio participaron varios médicos de aquí de Médica Sur como Norberto Chávez, Francisco Valentín y Naúm Méndez. Por otro lado, está muy interesante los resultados y yo tengo dos preguntas acerca del estudio STRIDE. En muchas áreas de oncología, cuando los medicamentos funcionan en etapas avanzadas, cada vez se empiezan a usar en etapas más tempranas, tal como lo mencionaste en los take-home messages. Mi pregunta aquí sería si se ha pensado en tratamiento neoadyuvante, o sea, en pacientes antes de que sean sometidos a hepatectomía total o parcial. Y la otra pregunta, ¿de qué depende la magnitud del encogimiento, de la disminución del tamaño del tumor? Vi que va desde 50 a 100% y va bajando. ¿Qué es lo que determina la magnitud de la disminución del tamaño de los tumores?
Excelentes preguntas, muchas gracias, doctor. Sí, de hecho, el tratamiento neoadyuvante todavía no es estándar, sin embargo, ya se han hecho distintos estudios, principalmente prospectivos, en Estados Unidos y China, en donde el tratamiento neoadyuvante ha llevado a que los pacientes con las tasas de respuesta de los nuevos tratamientos, ya sea la doble inmunoterapia o la inmunoterapia antiangiogénico, permite que los pacientes puedan llevarse a trasplante o de hecho algún tratamiento quirúrgico. Esto es con la finalidad porque los estudios que tenemos de adyuvancia han sido negativos. Todos los pacientes recurren dentro de los 2 primeros años o a veces hasta después de los 2 años y todavía no hemos sabido cuáles serán las causas. Entonces, con el tratamiento neoadyuvante lo que tratamos de hacer es disminuir la carga tumoral, vemos el comportamiento biológico del tumor y también podemos ir determinando qué pacientes pudieran ser candidatos a estos tratamientos quirúrgicos o de trasplante. Sin embargo, todavía no es estándar porque no hay estudios fase 2 o fase 3 que nos han permitido ponerlo dentro de las guías de tratamiento, pero sí se han contemplado.
Yeah, I agree with the comments that have been said. I would just add here that the studies that have come out of largely the US have been relatively small. They've included different regimens. They've included single agent, sort of PD-1. They've included dual CTLA-4 and PD-1, and they've included PD-L1 combined with TKI therapy. They've looked at this both in resectable patients as well as quote-unquote borderline resectable patients. And as was said, the studies that have been done have shown pathologic responses, including a proportion of patients having major pathologic responses. A recent meta-analysis of those data showed that the proportion of major pathologic responses was around 20% of patients, and those patients with major pathologic responses had improved recurrence-free survival. At ESMO this year, we actually interestingly saw a trial out of China, which actually looked at the combination of camrelizumab plus rivasirnib, so a PD-1 and a TKI that's available in China. And in their large trial, actually showed improvements in recurrence-free survival. These agents are not available outside of China, and so we will want to see other trials with perioperative data. But overall, there's a lot of excitement for neoadjuvant therapy prior to resection to improve recurrence-free survival, particularly given that 50 to 70% of patients recur within 5 years after surgical resection. Likewise, from a transplant perspective, we've seen now data showing safety of immunotherapy prior to transplant. Initially, there was concerns about rejection, although with a washout period of around 3+ months, you can safely use immunotherapy prior to transplant. We have not seen any data showing improved clinical outcomes in those patients yet, We need to have larger studies to see if this actually is of benefit outside of, a bridging approach or downstaging approach, which I think we're going to see shortly. Now, your second question is interesting in terms of which are these patients. Both of them are interesting, but like the second question, I don't know if we have a good answer. You're right that we see variable responses. We see variable responses to any of our immunotherapy, even though that we see responses of 20 to 30% between the Himalaya trial and the IMbrave 150 trial. We know that there are cold tumors that are less responsive to immunotherapy, and then there are hot tumors that are more responsive, although we do not have any pretreatment signatures that are perfectly predictive of who is going to respond versus not. There have been things in terms of post-treatment, like there is an atezo-bev response signature that has been proposed, and so I think we're going to see many more studies come out in the future to help us figure out who are these patients responding versus not, but we don't have those data currently.
Pues muchas gracias. Antes que nada, felicitar a la sociedad por la excelente sesión. La verdad es que conjuntar a ponentes nacionales e internacionales de alta calidad es un gran esfuerzo y muchas felicidades. Y dos preguntas principales. La primera es, siempre en estos estudios dividimos a los pacientes que tienen cirrosis por hepatitis versus otros, ¿no? Y sabemos que la incidencia de problemas metabólicos y cirrosis secundaria en nuestro país es alta, pero también tenemos los pacientes con hepatitis autoinmune. Y la pregunta es, ¿qué tan importante es descartar que la hepatitis sea autoinmune antes de iniciar un tratamiento con inmunoterapia? Esa sería la primera pregunta. Y la segunda pregunta es, en aquellos pacientes que tienen carcinoma hepatocelular BCLC-B, que tienen recurrencia después de una quimioembolización, ¿cuánto tiempo o cuántas quimioembolizaciones después tenemos que esperar antes de iniciar un tratamiento sistémico de este tipo? Gracias.
Gracias, doctor. Excelentes preguntas. De la primera, ¿cuánto tiempo tendríamos que tardar? Todavía es heterogéneo cuántos tratamientos locorregionales. Sin embargo, en algunas guías está entre 2, máximo 3 tratamientos locorregionales antes de nosotros determinar pasarlo a un tratamiento sistémico. Esto en el Barcelona B. Ahora, determinar alguna hepatitis autoinmune antes de iniciar tratamiento, todo depende de la clínica y de lo que estemos sospechando como causa principal o factor etiológico de la cirrosis hepática. Si lo sospechamos, sí tendríamos mínimo que pedirle unos anticuerpos antinucleares para nosotros determinar el mejor tratamiento, porque sabemos que estos pacientes, son retirados de los protocolos de tratamiento con inmunoterapia, entonces no sabríamos si habría o no respuesta. Y 2, pues también sabemos que son estos pacientes que pudieran tener mayor riesgo de hepatitis autoinmunomediada. Y esto, por ende, en las guías está determinado como una contraindicación y de hecho se dan tratamientos con TKI.
Yeah, so I'll take the autoimmune question first. So as Dr. Conde said, these patients were typically excluded from the clinical trials with a history of autoimmune disease. My personal perspective is that, if somebody has underlying active autoimmune disease, they essentially have their own immunotherapy on board, right? I mean, they already have a lot of inflammation that is causing an immune background, so they are basically sort of proceeding with an IO type therapy. Those patients who develop HCC in the setting of autoimmune hepatitis typically do so when they have bland cirrhosis. The autoimmune hepatitis, the active disease, has often burnt out. So I think that at that point, the likelihood that you actually induce an immune-related AE when you have burnt out cirrhosis is probably relatively low. I understand why they were excluded from the clinical trials, because the last thing you want to do is include them and have a grade 5 AE for something somebody would have said, like, why did you include them? But at least in our clinical practice, if an IO therapy is sort of the best approach for that patient, we talk to them and we at least offer it in terms of a consideration. If somebody has a history of autoimmune disease, I'm actually much more likely to use something like a Tezo-Bev or a single agent. I'm less likely to use dual IO in that patient. But we have used this and done so in a safe manner. Understanding you're doing so with limited data in terms of the safety, but I don't think that it's quote unquote 100% risk of having an immune-related AE. Your second question about sort of the local regional therapy, how many TACEs, like when do you stop, should you use systemic therapy for recurrence? I would argue it's somewhat of a complex discussion, and I'm going to sort of break it down into 3 different points. The first is when a patient first presents in terms of BCLCB or intermediate stage disease, you have to assess how much disease there is and if TACEs or TARE or any local therapy is a good upfront approach. We've seen different definitions, like up to 7. When you add the size and the number, does it exceed 7? But I actually think that the biggest thing that I use in my clinical practice is the number of segments involved. You remember the old Akuta staging actually had greater than 50% liver involvement, and we've somewhat gotten rid of that over time. But I think that when I take a look at this, I want to know how many segments are going to be involved, how many segments are going to be treated, and if a large portion of the liver is going to be treated with local therapy, then I think of those patients as often being quote-unquote TACE unsuitable, and we instead use upfront systemic therapy, with the idea that we're hoping that that patient has a response, and we can thereby then subsequently deliver the local therapy in a more selective manner. So, Kudo and colleagues actually looked at this in terms of a propensity score matched analysis, and they showed better outcomes for patients receiving systemic therapy versus local therapy for patients with large disease. And actually at ESMO this year, we saw data from the ABC HCC trial also showing similar data that those patients with large BCLCB disease did better with upfront systemic therapy. Now, the second point of this is TACE failure. Patients who have TACE sort of suitable disease get treated with local therapy and don't have a good response. In our clinical practice, we give up to 2 local therapies, and if they do not have greater than 50% response, then we typically start to ask ourselves, what's the likelihood that we're going to induce a response with continued local therapy? And we thereby would consider systemic therapy. There's no perfect answer here. I think it really depends on what is the destination. Are you trying to get this patient a transplant, et cetera? But it's at least a consideration in that case in terms of TACE failure. The other part that I would look at in terms of TACE failure is also degradation of liver function. If you are able to achieve a response for your first therapy, but do so by taking somebody from LB grade 1 to 2, I do become a little bit more cautious about repeating that, because then by doing so, you would likely take that patient from LB grade 2 to Child-Pugh B, and thereby limit the future availability of therapies in general. There's no perfect answer. These decisions should always be made in a multidisciplinary manner. But that's sort of my general approach for TACE failure, TACE unsuitable disease. And I think the other thing that I'd say is just that you need to look at this longitudinally, because even if you transition to systemic therapy, it may be the type of thing where if you have a response, you're able to come back to local therapy in the future.
Hola, buenas tardes. Muchas gracias a los dos. My first question is for Dr. Singal. And now that we have the results from Checkmate 9DW, do you believe that this difference in overall survival is due to the study design, or it has to do with immunological intensification? And my second question for either of you is if you take into consideration the cause of the underlying cirrhosis when choosing any treatment, because of these rising numbers in MASLD and MASH. We know that these tumors and these hepatocellular carcinoma rising in this kind of liver, it's like a cold tumor. Mm-hmm. And there's less lymphocyte infiltrate, and maybe they could benefit, at least in theory, from an anti-angiogenesis rather than double immunotherapy, or the combination. Thank you.
Yeah, so great question. So the Checkmate 9DW, why is it positive? I think that my personal perspective is this reinforces the value of a dual IO regimen, CTLA-4 plus PD-1 or PD-L1. So I think that's the biggest thing that I take away from this, that it reinforces the STRIDE regimen and the Himalaya trial was not a one-off. It reinforces this is a good combination in this disease. Of course, any positive trial is a combination of having a good agent and good trial design. So I'm going to take the cop-out easy answer and say it's really related to both. And the reason I say that is I'll take the lenvatinib plus pembrolizumab sort of evaluation. I think of lenvatinib and pembrolizumab as being a very efficacious, potent combination. But we saw this fail when it was compared to lenvatinib in the first-line setting because of trial design and the way they set this up in terms of a comparator. Likewise, you can say Checkmate 459 would have been a positive outcome if they looked at it from a non-inferiority design. So we've seen good agents fall to the wayside because of trial design. So I think Checkmate 90W is in part positive because of good trial design, patient selection, but I do think it reinforces the value of a dual IO regimen in patients with HCC. Your second question about etiology and how this influences our treatment. I mean, some of us are aware of the study from Matthias and Josep and colleagues that was published in Nature that showed T-cell exhaustion suggested in preclinical data that IOs may be less effective in those patients with underlying MASH. And this raised a lot of concern because MASH is going to be the predominant etiology moving forward. And there was a question of should we be using IO in these patients with underlying MASH? There subsequently have been the release of a fair number of clinical studies that have actually refuted this as a true clinically significant sort of observation in humans. The efficacy of IO is probably the best in hepatitis B, is probably slightly lower in patients with non-viral disease, although the responses are typically fairly stable across these etiologies. And when one takes a look at the analyses from these clinical trials that have subsequently been published, once again, you can achieve good clinical outcomes in patients with underlying MASH. We did a post-hoc subgroup analysis using the granular clinical data from IMbrave 150, adjusting for some of the other factors. And actually, atezobev did just as well in MASH patients as other etiologies. That was published as a brief report in Gastroenterology. In the Himalaya trial, we see stratified analyses by etiology, and actually the STRIDE arm had similar survival estimates across non-viral, hepatitis B, and hepatitis C. Now, the relative benefit of STRIDE compared to the sorafenib arm was mitigated actually in the hepatitis C arm because sorafenib did better. We know this from long-standing studies that hepatitis C is where sorafenib performs the best. But the STRIDE regimen performed equally well across those etiologies. And we've now seen this observation across subsequent sort of IO-based studies. So in our clinical practice, we do not use etiology as a deciding factor for IO versus not, nor deciding between different types of IO-based regimens.
Thank you.
Ya última pregunta para pasar al ambiguo.
Muchas gracias a ambos por la plática, por tan informativa. Son dos preguntas muy rápidas, la verdad es que suena mucho a lo que ya dijo esta Fernanda. Si las diferencias entre el Checkmate y el Himalaya van como en la población o realmente sí estamos conformes con solo dar un solo ciclo, una sola aplicación de inducción con anti-CTLA-4 a comparación de los otros cuatro. O sea, sí, creo que nunca vamos a tener como una respuesta clara de cuántos tenemos que dar, pero ¿estamos cómodos con solo dar uno o sí realmente necesitaríamos un poco más de poder en esa parte, ¿no?
La respuesta sería, todavía no la tenemos y quién sabe si la vamos a tener, pero conforme a los estudios yo creo que sí estaríamos tranquilos, porque así, aunque tiene mayor supervivencia y probablemente sea por el diseño y el tipo de población que escogió el Checkmate, digamos que también más del 20% de los pacientes utilizó esteroide, la mayoría tuvo algún evento adverso grado 3, 4, inmunomediado. Entonces también son pacientes que recordemos que tienen una función hepática limítrofe y el tener una hepatitis inmunomediada con uso de esteroides también los estamos comprometiendo también a mayores descompensaciones hepáticas y probablemente hasta pasarlos a una falla hepática. De hecho, en el Checkmate 9, digamos que hasta hubo como a los 3 meses un entrecruzamiento de los pacientes, probablemente porque estos pacientes tuvieron un deceso por algún evento inmunomediado. No lo sabemos, pero sí sabemos que es muy tóxico. Entonces, creo que con una sola dosis, manteniendo esta respuesta inmunológica de la doble inmunoterapia y conservando la función hepática, creo que pudiéramos estar contentos y estables con estos pacientes. No sé, el doctor.
Yeah, no, I agree. I don't think we'll ever know the answer here. If you ask me sort of off the record and not sort of on label, I actually think the answer is somewhere between 1 and 4. I actually think that the answer is probably 2 or 3 doses is probably the optimal way, where you would then get sort of this sort of nice efficacy but preserve the safety. We don't have a regimen that does that right now. Interestingly, in the Himalaya trial, patients could receive a second dose of tremelimumab, and a handful of patients did. But we don't actually know why they received it. Those data are really messy, and so we don't actually have any good observations coming out for that sort of handful of patients. But I think that your point of can we potentially achieve the same outcomes of giving, for example, a single dose of IPI and then using nivolumab, I don't know if we don't have the data to support that. Like there's no data from sort of the 9DW trial to sort of say that that's the case or not. I personally tend to be a purist. The way that BMS evaluated ipi-nivo was to use up to 4 doses of ipi combined with nivolumab. The way that AZ evaluated STRIDE was a single priming dose of tremelimumab followed by durvalumab. So if you want a single high dose of CTLA-4, then I would use the regimen that was evaluated, and you have the data to support this. So that's just the way that I look at this. I've heard providers wanting to do all kinds of sort of modifications to the ipi-nivo regimen. Instead of using 3 milligrams, they want to use 1 milligram to have the safety profile. But we don't know what the efficacy of that regimen is. I don't think you're going to get this. You're not going to get the same survival if you use a lower dose of ipi. The only way they got that survival was high dose ipi. Likewise, if you use a single dose of ipi, not using up to repeated doses as tolerated, I don't know what survival estimate you're going to achieve using that regimen. I mean, it may be the same as STRIDE, it may or may not be, but I mean, there's differences in these agents. And so I think if you want a single dose of CTLA-4, in our clinical practice, when we want this, we use STRIDE.
Gracias.
Bueno, muchísimas gracias por su asistencia. Con esta excelente ponencia terminamos el ciclo académico del año 2025. Agradecemos muchísimo a nuestros patrocinadores AstraZeneca y los invitamos a pasar al foyer para comida. Tenemos salmón, filete y lasaña. Muchísimas gracias, que tengan muy buena tarde.